And welcome everybody to the DC Roadrunners Q&A with sports cardiologist Dr. Ankit Shah. We'll get going here in just a moment as everybody comes in through the waiting room. And as Peter Feltman was just mentioning, we will be recording this. We are recording this. So just to get that consent out of the way, by joining, you consent to being recorded. This will be posted to some various places that are available to the general public, so that you know. So that's disclaimer number one. I'll get one more out of the way and then we'll start getting into it. And that is, this is a session for informational purposes only. Our discussion is not intended to be a substitute for professional medical advice, a diagnosis, treatment, right? Always seek the advice of your physician. So this is informational purposes. Please don't try and self-diagnose any sort of cardiologic issues you might think you have through this call, much less through the internet. Okay, so I'm going to introduce our expert in just a moment, Dr. Shah, but I first wanted to share with you a few sentences of that I found just incredible about what the heart actually does. It is truly an amazing organ. From birth until death, it beats nearly 3 billion times. The amount of work it performs is mind-boggling. Each heartbeat generates enough force to circulate blood through approximately 100,000 miles of vessels. That's, I think, more than 4 circumnavigations of the Earth. The amount of blood that passes through an average adult heart in a week could fill a backyard swimming pool. And if you're looking to do the math on that one, I think you're going to need a very big calculator. So with that as background and introduction, let me go ahead and introduce Dr. Ankit Shah. He is the president of Sports and Performance Cardiology in Chevy Chase. He's the team cardiologist for USA Swimming. He's a cardiology consultant for the US Olympic and Paralympic Committee, and he's on the National Basketball Association Cardiac Advisory Committee. He is also an associate professor of medicine at Georgetown University and adjunct associate professor of medicine at Johns Hopkins University. Furthermore, after completing a dedicated fellowship in sports cardiology at the Massachusetts General Hospital, Harvard University, he was recruited to MedStar and served as the founding director of their sports cardiology program from 2017 to 2023. And during that time, he was the team cardiologist and sports cardiology consultant for the Baltimore Orioles, the Washington Mystics, the Washington Capitals, and the Baltimore Ravens. And lastly, in preparing for this call, I went to Dr. Shah's website and I learned that more recently he was one of 2 cardiologists charged with screening every athlete who came through the US Olympic and Paralympic Committee for any signs of cardiovascular disease. Wow. Dr. Shah, welcome, and thank you so much for participating.
Thank you so much for having me. Really excited to do this. Appreciate you all coming out tonight.
Perfect. So let me just set the format up of this. So please keep yourselves on mute. To give everybody a roadmap of this call, I'm going to spend the first part chatting with Dr. Shah to get just a basic understanding of the heart, plus a few topics that should be of interest to all of us. And then after which, we'll invite all of you into the conversation. You can ask questions in the chat box, which we'll be monitoring. And once we get through this initial discussion, we'll post those questions to Dr. Shah. Okay, so with that, let's jump into it. I've got some dumb questions. First question. What is a sports cardiologist? How are you different from a regular cardiologist?
Yeah, so sports cardiologist, I mean, it is what it sounds like. And so it's a cardiologist who specifically works with active people and athletes. And I think one of the things is we realize there's a clear gap in the care of active people and athletes. When you think back at general cardiology, in our training, you don't get really any dedicated lectures, training in exercise physiology and or working with competitive or regularly active people. And so if any of you have ever been to a cardiology office, you typically see an older population,
Yes.
chronically ill, barely can kind of walk across the street. And so it's a very different population, obviously working with you all compared to the general population. And what we, the way we approach things is completely different from the start to the finish of the whole visit. um, all of the data, how we interpret data. So EKGs, the echoes, which are ultrasounds of your heart, even cardiac MRIs, all have nuanced findings that can be normal or normal for an athlete, and in certain scenarios, if you're not trained, you might call something normal when it actually is abnormal for an athlete. So just saying that, oh, you run a marathon, you must be fine. And so there's specific findings that really sort of tailor it. The way we evaluate things is different, right? And so stress testing, if you've ever had a stress test, most of them will do a very slow walk uphill. It's not very physiologic, typically really hard because you're not used to slowly walking uphill and then jogging. And so we do much more physiologic tailored testing that tries to reproduce what you're going through. The way we manage things and treat things is different, right? And so different medications based on what the scenario is that are better for endurance athletes, don't cause dehydration, other things. So it's a very nuanced, tailored approach to the athlete. And if I'll give two quick examples of how this is different. We just published something in the Swimmer magazine, which is for master swimmers. And a patient of mine, holds multiple world records of open water swimming. And so he went to a cardiologist about a year ago and was having problems with his performance. And they're like, well, if you can still swim 3 miles and you hold world records, you're probably fine, and sort of dismissed it. And he's like, well, something's really wrong with me. Finally, he sort of was persistent and was an advocate for himself. And ultimately, he was found to have coronary heart disease and had to go through bypass surgery. And then on the end of that, on the back end of the bypass surgery, he was essentially told he could do whatever he wants in terms of activity. And he started swimming like 2 weeks after bypass surgery, which was way too soon. And so he came to me after that, and sort of we worked on a whole plan and all of that. But that case highlights two things. One, these sort of initial like misunderstanding or dismissal of symptoms because he was so active. And then the back end of how to sort of prescribe exercise to someone who's had heart problems now and getting them back to fitness.
Wow. Yeah, not like us is the thought that comes to mind. But
Right.
let me back up for a second and ask a super dumb question, which is actually, why does the heart exist? What purpose does it serve?
So at its simplest form, it is a pump, right? And so its goal is to send that oxygen and nutrients to the other organs and the working muscles. But as you read in that excerpt, I mean, it's a very intricate mechanism, and there's four big things that we can think about. So the heart muscle, which is the pump itself, and so for different people that can be too thick or too thin, too weak. You have valves. There's four valves, and those are normally sort of one-way doors that typically let blood only forward, and some people can have tightening of those valves or valves that are too leaky. Um, there's a whole electrical system that coordinates the effort, and then there's the piping or the aorta and the coronary arteries. And so the arteries feed the heart blood, so it can actually do the work that they do the pumping. And then the aorta is the big pipe that takes the blood from the heart and sort of is the conduit that then has branches and gives blood to the rest of the body and the organs.
It's so funny. I sometimes hear the heart dismissed as it's just a pump, and yet there's this enormous complexity still around it. And as I think we'll get into, one of the things that I've experienced personally that's very heartening is not only do you cardiologists have a lot of tools by which to diagnose all of those elements that you've just described when they go wrong, but you also have a tremendous array of treatments and things that you can do about that, as opposed to some other disciplines where they don't have that at all, where it's far more limited in terms of what they're able to do, which is just tremendously, I guess, heartening. Okay, so very helpful. Let me ask you then, going back to something you mentioned a few minutes ago in your example of the competitive swimmer. So what is different about runners' hearts versus those of non-exercisers, and how exactly does exercise change the heart?
So you've probably all heard of it, the athlete's heart. In the scientific literature, we call it exercise-induced cardiac remodeling. And essentially what we've seen and what we've learned is that if you do enough of the exercise, that stimulus, you see adaptations. The old data, the original data, essentially was done on people predominantly doing over 10 hours a week of training. And we saw the heart adapts. And before we talk about specifically runners, I mean, the bigger picture is not all sports are created equal, right? And so there's a different component of both strength and endurance requirements per sport. So if you're a track sprinter doing 100 meters, it's going to be a little bit different than running a marathon. Where running a marathon is almost purely aerobic, and then the track sprinter is going to have a lot more strength plus that other component. If you're doing primarily weight training, heavy weights, that's obviously purely strength with very little aerobic. If you're doing a sport like rowing, you're going to have sort of the extreme of both, where it's just the demands of aerobic and strength are really, really high. And so if you start in the bottom corner for the sedentary person who's healthy but not exercising, you're going to be here, your heart sort of say the normal baseline shape. If you're doing aerobic training primarily, you're going to see sort of four-chamber dilation. So all four chambers of the heart can get bigger and dilated. And the way to think about that is when you're running, your heart rate's up for a longer period of time. You're funneling more blood through the heart. And so the stimulus is experienced by the entire heart. It's not just one chamber. That blood flow is going through all four chambers of the heart. And so they're all exposed to that stimulus. And because of that, all of them sort of get dilated. If you are in the strength component, it's primarily a pressure load on the heart. And so what you see is you can see thickening, and it's really only of one chamber because only one chamber is experiencing that pressure load, and that's the left ventricle, the main pumping chamber of the heart. And then the rowing is because you see both, you can see both thickening plus dilation. So you have dilation of all four cavities plus some thickening of that left ventricle. And so when we think about the person in front of us, a part of our first visit is an exercise history. How long have you been exercising? What have you done in terms of exercise? Because then in my head, based on your sex, age, and your exercise history, I'm going to have sort of an idea of what I think your heart should look like. And if I see something completely opposite, I'm going to be alarmed.
That's interesting. So there's like a different baseline, and that baseline is going to depend not simply on whether someone is conditioned or in good shape, but the nature of the exercise they do, from being a runner versus, say, a weightlifter.
Absolutely. Yeah.
That's really quite remarkable. And then when you mentioned the dilation of the chambers, if I understood correctly, what you're saying is there's just a lot more blood that has to get circulated through the body when it's exercising. And so the heart the chambers, every chamber expands to be able to accommodate that higher volume. Did I understand that correctly?
Yeah, that's exactly right. So at rest, we're all pumping about 5 liters per minute of blood. When you're doing regular, like vigorous exercise, you can put that up to 25, 30 liters a minute.
Wow.
And so the response is the heart gets bigger, and that's one of the hallmarks of the athlete's heart is what's called the stroke volume. How much your heart pumps with each beat gets a lot higher. So you're able to pump more with each beat. And as I think we'll get into thinking about VO2 max and all of that,
Yep.
that's one of the hallmarks.
And so then that, I think, explains why we all have lower heart rates than non-exercisers. Because when we're just sort of sitting still, our heart can just sort of get a lot more out.
Yeah, exactly. Yeah. So exactly. If you use the same example of rest, there's an equation of it's heart rate times stroke volume. So heart rate, we know stroke volume again is how much your heart's pumping with each beat. And say that's 5 at rest. If your stroke volume goes up or doubles, you can half your heart rate and still have the same net output of that 5 liters per minute. Does that make sense?
Interesting. Yep, it does.
And
Yeah.
so the heart rate, the peak heart rate's not a trainable number. So we've all heard the calculator 220 minus your age. And so
Yeah.
as you get older, your heart rate, your maximum heart rate does come down. And no matter how much you train, you can't train that to be higher. Now that equation itself is not very good and has a very wide standard deviation. So we can talk through that. I don't recommend using that, but just from the global perspective, your peak heart rate will go down with age and you can't train that up.
Interesting. There's an analogy there. I think with eyesight, as you get older, your ability to focus more closely goes away. So you have to hold things farther away. And that's apparently it's quite possible for people to be aged. You can estimate someone's age just by how far away they can focus. Okay, let's start getting into this. So two sayings runners are familiar with. One, you cannot run a bad diet versus everything burns if the fire is hot enough, even Big Macs. So just leaving aside the nutritional and fueling requirements and just specifically on cardiovascular health, which one of those is correct? Do runners need to eat heart healthy, or can they kind of get away from it, or get away with it rather?
Yeah, I mean, I think this is a big mistake that a lot of athletes do, right? And so you might not put on weight, you might stay fit, and because you're going to burn those calories, but what you put in definitely has a huge impact on your heart health. And so, a lot of the folks that I'll see, we ask about that dietary history. So your 20s, 30s, 40s, and if you see them in their 50s, like, yeah, I've been running my whole life, but yeah, my 20s, 30s, and 40s, I ate whatever I wanted, the American burgers, chips, fried food, all that stuff. But I maintained the same weight for 30 years. That's great. But what the heart saw through that and the cholesterol impact and blood pressure impact, all of that is definitely has detriment and side effects to that. So you should be eating a good balanced diet. Just because you're exercising doesn't sort of give you free reign to do whatever you want.
So then I think that another statement, I don't need to worry about my cardiac risk factors because I run daily and I'm very fit. So it sounds like that statement is not true.
Not true. Yeah. And this is, it's a misconception, the idea of that, yeah, exactly. I run every day of the week, I run marathons, I have no heart problems. Unfortunately, that's not true. We do know that more and more exercise is great for heart health, and the fitter you are, the longer you live, all of that is true. But if you have underlying risk factors that are still there despite your running, they should be addressed. And
Mm.
so if someone is sort of sedentary, has a little bit of high blood pressure, a little bit of cholesterol, and they start running and everything normalizes, that's fine.
Hmm.
But if you're running 6 days a week and 50 miles a week and you still have high blood pressure or your cholesterol is still very high, you can't kind of just ignore that and saying I'm running, so I'm good.
One of the questions that we did have, or that I had in the run up to this, was just that. How the hell can I have high blood pressure when my resting heart rate is 44?
Yeah, it's some of it is genetic component, right? So if you have a strong family history, some of it's dietary, and then some of it blood pressure. We know, as you get older, your likelihood of having high blood pressure is going to be higher.
Yeah.
And another thing about blood pressure is people always say, "I feel fine." Blood
Mm.
pressure is typically not something you feel. And so you could have high blood pressure for years without knowing it unless you actually
Oh,
check it. So it's called the silent killer. It can go undetected for years if you're not actually being seen by a physician or checking blood pressures at home.
wow. Um, so let me ask you a question about some research that you published just a year ago about female endurance athletes' hearts versus those of males. And as we know, much of medical research, not just specific to your field, but I think broadly, tends to recruit overly so from the male population, and I think specifically often the white male population. So there are differences. And I wonder if you could just share the findings of that research and the major takeaways for our audience. Is there anything in particular female athletes need to be aware of?
Yeah, thanks for bringing this up. I think one of the main highlights also of this paper was that, as you just noted, we need more data. The old historical data on athletes is primarily driven in white men, as you noted. But from the data we have, a lot of it is actually pretty reassuring. And so a lot of the signals of potential harm or potential risks seems to be higher in men than women in terms of athletes. And so when we talk about, I think we're going to get into like atrial fibrillation,
Hmm.
coronary artery disease, all of those in female runners, it seems to be lower. So the risk is lower. Um, and the heart remodels a bit differently, meaning you don't see as robust of a change. And the VO2, when you divide it per kilogram per minute and sort of you're indexing it to the person's size, is a little bit lower than males. But from a risk perspective, atrial fibrillation, the coronary disease, the risk of death, all lower in female athletes than male athletes. So that's good news for women athletes. But I will just make a caveat that, again, the idea of risk factors shouldn't be ignored. And the risk profile tends to change post-menopause. And so for women in general, once they go through menopause, their cardiovascular risk factors typically change. And then at the end of the day, heart disease is still the number one sort of killer for men and women in the US.
So when you say those risk factors change when women go through menopause, like what kind of risk factors do they now have? Is it like high blood pressure, hypertension? What changes?
Yeah, I think a lot of women notice that it's harder to keep weight off, and so they might see increases in weight.
Mhm.
Blood pressure goes up, and then cholesterol typically goes up as well.
Mm. Okay, so that's the sexes. What about ages? So we have a very wide range of ages in DC Roadrunners. We have everybody from their 20s to beyond their 70s, I think. So what should runners be doing to take care of their hearts, depending on, whether they're in their 20s, 30s, 40s, et cetera? Should a runner in their 60s, for example, be doing anything different as far as heart health than someone in their 40s?
I'd like to start by saying across the board, everyone should have a primary care physician.
Hmm.
Whether you're healthy or not, whether you're young or old. An annual check-in is really important for multiple reasons. One, they might detect something that you're not feeling, so high blood pressure, something in your cholesterol if they check your annual blood work. And then separately, it's really important to have established care with someone, because if at some point you develop symptoms, he or she will have had sort of an understanding of who you are, and when you come with symptoms 2 years down the road, they're going to, one, hopefully take it more seriously if you've been seeing them and they know you. And then two, they might actually be able to sort of target more exactly where they need to go in terms of evaluating those symptoms. From outside of that primary care or medical establishment, from a heart disease perspective, we've sort of, it's not obviously black and white, but we've sort of delineated less than 35 years old when they run into issues is typically congenital or genetic heart problems.
Mm-hmm.
And then above 35-year-old, it's sort of more of acquired heart disease, whether it be coronary artery disease or other things that you've acquired over your lifetime. Again, not black and white, and it's sort of it can span across, but in general, the younger athletes, that's what we worry about. But those younger athletes obviously are going to get older, and so the idea of, again, if you're in your 20s and 30s, making sure you know your numbers. Don't just assume that you're healthy. Get checked out, and if those numbers aren't accurate, and you're exercising 5-6 days a week, we're not going to expect a tremendous reduction if you increase your mileage. And so from like a risk factor perspective, when you're doing nothing and then you start exercising, you can see dramatic changes in your blood pressure and your cholesterol. But if you're already working out 5-6 days a week, 3, 4, 5 hours a week, if you go from that and add another hour or two a week of exercise, you're not going to see that much more of a dramatic improvement in those risk factors. And then from the, I mean, I think across the board of all the athletes is really listening to your body. And so, if you've been running and you know what normal feels like, if you start feeling things that are abnormal, don't just ignore them. That should be a sort of a red flag to be like, okay, I've been running for 10 years and I've never had burning when I run in my chest. I've had it a day or two for no reason. Then I should pause and seek care. And then same thing. I mean, I think for the older athletes, if you have known heart disease, I think partnering with someone who understands what you're trying to do can give you sort of an exercise prescription or talk about risk and get an idea of what's important to you. There's people who want to run marathons or half marathons but don't need to, and they're saying, just tell me exactly what sort of I can stay healthy but exercise regularly. And then there's people who say, regardless of the type of form of heart disease I have, I still want to do a marathon or sprint a 5K. And so having that nuanced conversation, understanding the risk is going to be helpful.
Lots of things that you just mentioned are quite interesting to me. First of all, getting kind of a baseline so that you know what passes, or your physician in particular knows what is sort of normal or steady state for you, so that any changes then become something that are flagged. Secondly, that you mentioned this idea of kind of like, I don't know if it's sort of, you think of it as degrees of freedom or sort of room to improve. If you've got some numbers that are concerning and you're kind of not exercising can provide a tremendous benefit for some of those, but for probably everybody on this call, if there's not really much room to improve. So if you're running 40, 50, 60 miles a week and you add another 10, you're not going to see the health benefits that would come from somebody who is going from 0 to 10, say.
Exactly right. Yeah.
And then there's one other point I wanted to circle back to, which in my own experience in doctor's offices taking blood pressure measurements, I will just say that I feel 8 times out of 10 they're doing it wrong. From my reading, you come in, you sort of rush in, they sort of slap the collar on you. You're sitting up, so you're not like, your back is not reinforced, so you're like, your gut is kind of tensed. And then they take the pressure, and whatever it is, they're like, oh, white coat hypertension, like there's never any sort of, it's like just they're checking the box. So how should runners, or all of us, what is the right way to measure our blood pressure so that we really do know if it is just, okay, I haven't been sitting still. These guys just sort of, gave me a little core clinch and I have white coat hypertension. So what is the right way for us to do that?
Yeah. So before I tell you, I'm just going to make a comment about the white coat hypertension. So in the past, we sort of have blown that off and said it's pretty benign. Don't worry about it. You're just nervous in the office. There's more data that there's probably something real behind that, right? And so if you're able to get your blood pressures high enough in a medical office, there might be something real. And so we're not as much sort of saying, don't worry about it. We generally have people go home and do home blood pressures and really focus on what's happening because we want to treat it if it is high. Now, in terms of how you actually check it then, so the ideal scenario is you're at home office, but in a quiet environment. You've been seated for 5 minutes, which never happens when you're running into an office. So seated for 5 minutes, both legs on the floor, quiet environment. So you didn't just get off a work phone call or have a conversation. and then you want to have your arm at sort of your heart level, and you don't want to be holding it yourself. You want to sort of having it resting on a kitchen table or something. You want to use an arm cuff and not a wrist cuff. So if you're going to
Mm.
buy a blood pressure cuff, it shouldn't be around the wrist, go around the arm. And then you take your pressure. That's sort of the ideal environment scenario. And then what I typically have people do is take it, and you shouldn't be doing it 10 times a day because it sort of you can spiral with that.
Yeah.
And so I typically have people check it, 4 or 5 times a week for 3 weeks. You get like 15 readings.
Mm.
And so it'll be like Monday morning, Wednesday afternoon,
Mm.
Friday PM. And so you have a range of different times of the day, different days. And the important thing for runners is don't cheat and check it right after running because it's going to
Oh.
be lower.
Ah.
So exercise reduces your blood pressure. So for a few hours after running, it's going to be low. So
Ah.
yeah, so we sort of get a whole spectrum of exercise of blood pressures, but not specifically after running.
That's very helpful. I didn't know that. And of course, runners tend to overlap considerably with type A personality types. And so there will be probably an innate sort of drive to compete on sort of with oneself on blood pressure. So that's very helpful. And then what passes for normal blood pressure, by the way? Because that's changed a little bit, hasn't it?
Yeah, so historically, over 140 over 90 was considered high blood pressure, and normal was less than 120 over 80. So that number has stayed the same. So normal is less than 120 over 80. But now they're sort of graded it into a sort of like pre-hypertension stage one. So above 130 over 80 is now considered elevated or high blood pressure. And again, the idea of when you treat it with, when you encourage a lot more lifestyle modifications versus treating it, doing lifestyle plus actual medications,
Hmm.
depends on your age and your other risk factors, and and how aggressive, based on all of those things that we're going to be.
Okay, great. All right, there was something I wanted to circle back to as well, which was when you were talking about maximal heart rate, and you mentioned that that is a sort of a law of age. So let me ask you about what the best way is to understand what your maximum heart rate is. And related to that, is there a heart rate that runners should stay below?
Yeah, so the 220 minus your age is not a good metric to follow if you're going to try to create heart rate zones or give yourself like an exercise prescription with someone. Um, the standard deviation of that is about 12. And so for those of you who remember math, the 95% confidence interval is about 24 beats. And so, for example, if you were a 20-year-old, the equation would predict your maximum heart rate was 200. But in reality, for any given to healthy 20-year-old, it could be, what is it, 180, 176 to 224,
Mm-hmm.
which all be considered normal. And so if you're going to now create heart rate zones, or give yourself a governor based off of heart rate, you're going to be wildly, misled.
Yeah, that's not
Um,
calibrated at all.
so then how to do it? One, you can do like a maximal effort stress test in an office setting. Or second, you guys are typically have all the gadgets and wearables, and so you can do track workouts and do some sprints and see what your heart rates get to yourself, your personalized sort of heart rates. Um, and you'll know what your maximum heart rate is. In terms of heart rate below, like what's your maximum heart rate you should train at? I mean, to be honest, in the absence of heart disease, it's sort of arbitrary to give yourself a cap.
Hmm.
So people always ask me, I'm 45, should I not be getting my heart rate over 180? Or I'm 65, I shouldn't go above 160. There's no real science or reasoning behind that. So if you don't have heart disease, you have no symptoms, there's nothing being diagnosed, there's no necessary reason to give yourself a cap.
Interesting. And is that something that, not respecting age, if there's some theoretical or hard max by age, presumably you through training can increase that if you, I guess that would be, or is that something that is more like, I guess I'm just wondering, you said that it's don't give yourself a cap, but at the same time you said by age there's kind of a cap.
Right. No. So your maximum heart rate will decrease with age.
Okay.
But I'm saying is that you don't need to say, okay, I'm now 60 years old, I'm going to buy a watch and not train above 140, sort of completely
Oh,
arbitrary.
gotcha. Gotcha.
But when you're 20, your heart rate might have been 200, and now if you're 60, your heart rate may not go above 160.
Gotcha.
But that's not giving yourself a cap. That's just
Yep.
your new physiologic sort of limit.
Gotcha. Perfect. Okay. So you mentioned watches. So tons of metrics on wearables these days. And it's frankly confusing about how these get measured, whether they're important, and should we even just care about these. So I'm going to throw out some of these metrics, and I'll just ask you to tell us what it is, how is it properly measured, and should we care about it? Resting heart rate.
Uh, in terms of before we talk about the metrics, I'll just say some of this in general can be helpful.
Mm-hmm.
If you're a person that's going to sort of really focus and hone in on this and get sort of obsessed with it, it can be sort of harmful
Yeah.
because it can send you down sort of the rabbit hole, and things might be just fine and you're focused on things. But so resting heart rate, yes, it's a great metric, right? And so part of that initial equation we talked about, so um, your cardiac output, which is how much you're pumping per minute, is
Mm-hmm.
heart rate times stroke volume. And so if you're a runner and you start at baseline, you start training more, your stroke volume, which is at how much you can pump per beat, goes up. And as a response, your heart rate can come down. So at rest, you might see your resting heart rate go from 60 to say 40, 45.
Mm-hmm.
In the absence of symptoms, meaning you're not feeling lightheaded, dizzy, or passing out, that is typically sort of a normal training related phenomenon, and it's a sign of health, and we
Mm-hmm.
don't do much about it.
What
Um,
about, let me ask you variation in that. Some people I've read will look at resting heart rate and use that as a proxy for their sort of, availability to train, or sort of like how fatigued they are. Is that a valid use of that? And if so, like what is the variance that you would be looking at to let you know if, hey, you can go hard today or shouldn't go hard if you were looking at that?
Yeah. So this is where it gets really nuanced, and you really need to sort of have your own personalized data of what your normal ranges are.
Mm-hmm.
The heart rate can increase if you're like if an illness is coming on, you might see your heart rate go up a couple beats.
Mm-hmm.
If you're very dehydrated, very fatigued, if you're overtrained, meaning you're training too much and you're not giving yourself enough rest, you can see your heart rate go up. If you've had alcohol or a couple bad nights of sleep, your resting heart rate will go up. And so a lot of that can be signs or markers of, okay, I need to rest. But again, if you're feeling well and you're not sort of really, if you're not sort of competing for the podium, it
Mm-hmm.
may not make too much of a difference if you still go out on your run. So, I mean, at
Mm-hmm.
that point, just listen to your body. If you feel fine during your run, keep going. I wouldn't stop running just because your heart rate went up 5 beats at rest.
Right.
But, for again, those really competitive runners who are doing podium type stuff and going for a couple seconds or milliseconds here and there, then they're going to have a very detailed, tailored plan.
Perfect. VO2 max, you mentioned that earlier. That's something that runners are very familiar with and at the same time probably not very familiar with. So could you explain what that is, how it gets measured, and why it matters to runners?
Yeah, so VO2 max is your essentially your oxygen uptake. And so that the equation for that is a lot of what we've just been talking about. And so that's why there's sort of a direct relationship with what we do in sports cardiology with performance and VO2. So that VO2 is heart rate times stroke volume, and then times essentially the difference in your oxygenation in your arteries and veins.
Mm-hmm.
And so when you think about at rest, we've already said that, or with exercise, the heart rate's not trainable. The your If you have normal system, your arterial oxygen levels are going to be normal, and those aren't going to get higher. And then for some people, as you get really fit, you can extract a little bit more in your venous side, but that's not going to contribute a lot to the VO2. And so then predominantly you have this stroke volume. That's what changes. And so what the VO2 allows you to do is you need to take up oxygen and circulate that to your working muscles to do work. And so in order to run 8 miles an hour, 9 miles an hour, 10 miles an hour, you need more and more oxygen to get delivered.
Mm-hmm.
And so the way you do that is take up oxygen at your mouth that gets transported by the heart to your working muscles. And so there's a linear relationship between that and what work you're doing and your VO2. And so when you think about performance for runners, you want a higher VO2 because that essentially is the hallmark of aerobic fitness.
Mm-hmm.
Now, the VO2 is not the only story in the game here. It's so if you have a high VO2, doesn't mean you're just going to win a race,
Mm-hmm.
because for endurance runners, half marathons, marathons, you need the VO2 really high. But then the next thing you need is what's called the ventilatory threshold or lactate threshold,
Mm-hmm.
right? Because you're not running at your VO2 max. By definition, you're going to be past your lactate, and you can't sustain an effort for 2, 3 hours or 3.5 hours at that VO2 max. But if you have the ventilatory threshold, and that's essentially, when we do a VO2 max in an office setting, we're not measuring lactates. So we're measuring what's called the ventilatory threshold. It's very similar to a lactate threshold, but in lactate threshold, you're actually drawing like an earlobe blood and drawing curves. But that's where you go from sort of moderate intensity exercise to more intense, vigorous exercise, and
Hmm.
where your lactate starts accumulating. Um, and so with the VO2, you want that higher. And then for the sort of the second hallmark of an elite runner is that the ventilatory threshold is as high percentage wise of that VO2 max because you can run endurance events at your ventilatory threshold. So if you can get your ventilatory threshold to be, say, 90, 95% of your VO2 max, and you have a high VO2 max, all of a sudden you're in a good spot because you can run your race almost at your VO2 max.
And that, I assume, is what makes elite athletes elite. One of the things is that they are able to get that much more out of their heart. So there's that like that break point that you're mentioning, that threshold. So they
Those are the
do
two
that
things.
better.
It's the VO2 plus that
Yeah.
threshold so the VO2 is very high, and then the threshold is as close as possible to that VO2. And then there's things like running economy that's not specific to the heart,
Hmm.
but that adds in terms of performance.
So you're getting into now this, I think this would be a good time maybe to talk about heart rate zones. And they tend to get bunched or rather categorized into zones 1 through 5. So could you explain what heart rate zones are, how they relate to what you were just discussing of uh, lactate or ventilatory threshold and VO2 max?
Yeah, so heart rate zones get tricky. So the first sort of important note is that, like the maximum heart rate, so if you're going to use predicted equations, you're going to sort of really have trouble with your training because it's not going to be accurate or tailored to you. And so if you look online, you'll have these zones 1 through 5, and they'll say, use your maximum heart rate, your resting heart rate, and then you'll create these zones like 60 to 70% of this of that difference is going to be zone 3, 70-80% is going to be zone 4. So the first problem with it is the maximum heart rate we talked about. Using equations bad. And the second part is that not everyone reaches those zones at the same percentage of their maximum heart rate. So if you created a zone 2 that's
Mm.
40 to 60% of your maximum heart rate, for you it might be 50 to 70%. And so
Hmm.
now you sort of have two areas of error in creating your own tailored zones if you're using two different equations, and your training can be completely thrown off actually. And so a couple of ways to actually do it is to measure lactates, and so you can buy a lactate meter yourself and do tracker workouts and measure lactates. We can do them in an office setting, or you have the VO2 or cardiopulmonary exercise test, where we can measure the peak heart rate you're getting in the lab, measure the heart rate at your ventilatory threshold, and then use that threshold heart rate to then create zones around it, which are more sort of personalized and tailored to your own physiology. So if you get your threshold heart rate, you can create zone 3 from that, and then the rest of the zones go up and down from there.
How mutable is that? Changeable is that? Because I'm sure everybody on this call or many people in our club will go through various training segments where they may go through a speed segment one part of the year. They may train for a marathon or half marathon or even more another part of the year. How much is that sort of changeable, a snapshot in time versus more kind of fixed? How much do these things change?
So they can change, and a lot of it has to do with where you're starting from.
Hmm.
So if you're sort of an elite runner who's optimize all these things, you might not see dramatic improvements. If you're just getting started, you can see pretty tremendous improvements every sort of 9 to 12 weeks. And so we can repeat these tests every 3 months, and you can see improvements. You'll see shifts in your heart rates, and so you can redo your zones as your fitness is changing.
Interesting. So I want to come back to this question of different zones in a moment, but as long as we're on the topic of sort of these wearable metrics, there's one more that I think has really gained a lot of attention over the past, 5, 10 years, and that's heart rate variability. Could you explain what that is and whether we should care about it?
Yeah, this is another challenging one. So heart rate variability is the beat to beat variation. So say your heart rate at rest is 60 beats per minute, but between each beat, it might be a little, they're not all 1 second apart. So some of
Hmm.
them will be, say, 0.8, one's 1.2 seconds. And so there's going to be some variation in the beat to beat. And the higher that variation, sort of the more sign of health. And when the heart rate variability is low, that suggests there's something wrong. Now, the problem with this is that we don't know what normal is. So there's no normative data across and saying, so like for a 50-year-old male, this is normal. For a 30-year-old female, this is normal. We don't have that data. And
Hmm.
so really it should be personalized where You should
Hmm.
take your own data over some time when you think you're feeling well and say, okay, over the past 2 months, my heart rate variability is X, say 60 milliseconds. And then you use that kind of as your baseline. And similar to heart rates, if you see things trending in the wrong direction, it may suggest an illness is coming, you're overtrained, you haven't slept well. Um, Again, it's pretty nuanced, and you really have to have a good understanding of all these numbers. Um, I feel like for a lot of people, they just run into issues, and they'll take a day off of running because their heart rate variability changed by 10 milliseconds, and but they felt fine. And so I think in general, I don't advise necessarily checking it because we don't have hard parameters on how to sort of guide what's normal and abnormal.
Yeah. It's funny. I mean, I'm listening to you and I'm thinking about it as sort of a descriptive statistic or, lagging, but also like a leading indicator, like you could be getting sick. But I mean, I found in my own personal experience that I don't necessarily know how the run is going to be until I start the run, and then I go back and I look at these things and I go, well, these were not very predictive at all.
Yeah.
And which is where sometimes I wonder, being, uh, I suffer from analysis paralysis. I look at all these things and sometimes I think, maybe a Timex Ironman really would be better for me.
It's one of those things where it's like if you're going to collect data and you're going to use it, you should know how to interpret it and how it's going to impact you. If you're
Yeah.
going to just have data, then you're just going to sort of make you worried, but we don't know how to change how it actually impacting you. It's not obviously not beneficial.
Yeah.
And so part of this is just be careful with what you're trying to accumulate and gather. And if you just want the data there, but you're still going to listen to your body and some of the other parameters, if you're working with a physician, great. But if you're
Yeah.
going to try to sort of really get nuance with every change in your heart rate variability, I think it's going to be detrimental for a lot of people.
Exactly. Oh, it went from 50 to 51. What should I do?
Yeah.
Okay, listen, I see that there's one question posted to the chat. I've got another grouping of questions to ask, but please, as you have questions for Dr. Shah, just please post them in the chat. We will have, I think, time to get to them. I want to now turn to talk about sort of a section I've highlighted in my notes as risk, complications, symptoms, and when to call a doctor. So let me start with this well-publicized study, or maybe there's more than that, research a few years ago that posited that the benefits of exercise followed a sort of a U curve, that there were benefits, but then beyond a certain volume, additional exercise carried greater risk and could be harmful. Could you just explain those findings to us and what the current state of sort of understanding is on this? And is there any kind of red line that runners should not cross, like running more than X miles a week or some other element of exercise?
Yeah. So if you look at, again, a lot of this data starts with a sedentary population. So if you're a sedentary population, your risk is the highest of having, cardiovascular risk factors, bad outcomes, heart attack, strokes, death. As you go from doing nothing to doing some exercise, there's a pretty significant and dramatic decline in both risk factors and improvement in cardiovascular lifespan. And so the current recommendations for the average American are like doing 150 minutes to 300 minutes a week of moderate intensity exercise, or 75 to 150 minutes of vigorous exercise, because you see that pretty dramatic reduction. They think that's an attainable number for most Americans. It's like 30 minutes a day of just brisk walking. And then it's not a linear relationship though. So if you start, it doesn't keep going straight down. It sort of does. It's like a curvilinear thing where it sort of does plateau.
Mm-hmm.
And so there's continued improvement, probably up to 3 to 4 times those recommendations,
Mm.
where but the incremental benefit of adding each hour of exercise is a
Mm-hmm.
little bit less and less.
Mm-hmm.
And so probably 3 to 4 hours a week of vigorous exercise is sort of a sweet spot of getting the most reduction in cardiovascular risk factors, the most improvement in cardiovascular health. So what we typically tell people is that if you run marathons, if you want to train 10, 15, 20 hours a week, it shouldn't be primarily just the same because I want to keep my heart healthy,
Mm-hmm.
right? And so you don't need to do that much. And so you should be doing those things because it's good for your mental health, because you enjoy it. You're in a run club and you like running with your colleagues, because you're competitive and you just need that edge. And this is your substitute for sort of more dangerous things like alcohol,
Yeah,
drugs, and other
exactly.
things, right?
Time spent running is time spent out of a bar, right? Or yeah.
Yeah, right. And so that's an important thing. And so I just say if that's the reason, then that's okay. But you shouldn't do it primarily because of heart health, because that's too much.
Mm-hmm.
And so the initial thought was there's sort of this curvilinear and it plateaus out. there's some data that's what's called that U shape or reverse J shape, where there's maybe an uptick at the highest amounts of exercise. So again, doing nothing is the highest risk. Doing moderate amount is sort of the best risk, and it improves a lot of things. And then there's some concern that you start doing a lot of exercise, 5 to 10 times the recommended amounts, and there might be an uptick in a couple things. There are some studies looking at mortality that were very poorly done, and there's never been any real substantiated evidence beyond that. And so everything that we've seen is the fitter you are, the more exercise you do, you live longer. The couple signals that probably are real is atrial fibrillation. So that is an abnormal heart rhythm, where your heart's sort of the top chambers of your heart, instead of squeezing nice and synchronized, one of the chambers sort of quivers. And there's been consistently in long-term endurance athletes, we see higher risk of AFib. And this isn't someone who just started running 2 years ago. This is, people doing years, 5, 10, 15, 20 years of high volumes of running. So not just the person going to the gym for half hour, 3 days a week. But there is a signal of higher risk of AFib. Coronary artery disease, there's been a lot of data on calcification of the heart arteries in runners.
Yeah.
And so that's a fascinating story. I mean, a lot of the early ones didn't necessarily account for the risk factors. And so they've sort of just looked at running histories and said, okay, these runners had, higher calcification. But like we were talking about earlier, I mean, there's a lot of people who started running at the age of 40, and for 20 years, they sort of really beat up on their bodies with alcohol, with bad diet, with no exercise, maybe obese or overweight. And then they started running. And so if you get into the study when you're 50 and now you've lost all that weight and things are better, they didn't account for those 20 years of sort of damage you did that had nothing to do with running. And so a lot of the studies I think we've sort of looked at and said maybe there are some underlying risk factors, family history, obviously that plays a huge role. But there is an increased signal of calcification of the heart arteries in runners. But again, no signal of increased harm, which is the end all of what we care about: heart attacks, deaths. And so those are the sort of the three big things, but I think the strongest one is the atrial fibrillation.
Yeah. And now you said that tends to be a higher incidence among long-term endurance athletes. Did I hear you say that correctly? So lots of volume over an extended period of time.
Yeah.
There was something that I wanted to touch on that you mentioned, which is the calcification of arteries. I have read of studies, again, I think it's long-term endurance athletes seeming to have a higher level of calcification of their arteries. And yet, when there's a number of different sort of hypotheses about this, one of which is that they may be stable plaques, because they're also looking at the fact, I believe, of what the research points to is that their mortality rates are not higher than the general public. So there seems to be something different about what's happening. Could you just explain that a little bit more? What's that research say, and what's the interpretation?
So the research suggests that long-term endurance athletes, so high volume, long-term endurance athletes, have higher rates of calcification of heart arteries. We just take a step back. There's two types of plaque in the heart arteries: calcified plaque and non-calcified plaque. We typically think of the calcified plaque that has sort of a calcium cap on it, and so it's more stable and less likely to sort of break off and cause heart attacks. And so in these athletes, there's been shown that there's a higher rate of calcified plaque compared to sort of controls. Again, some of the concerns is that what are their other risk factors look like? What was their whole lifelong history of of diet, exercise, weight, alcohol, family histories? So how much of this is due to running versus other things that we're just not accounting for? And then in terms of the potential impact, if it is purely running, is that just the high volumes of blood flow through the arteries can create some turbulence and some sort of injury locally, and that's what causes that plaque. But again, there's never been a signal that it's increasing harm. So there's a finding that you have more calcification, but all the data we have says that runners and long-term, swimmers, triathletes live longer and do better. And so it's not that you have higher calcium and more risk associated with that. So that's not true. And so it's still sort of an area of active investigation.
Interesting. Okay, I see we're starting to get some questions in the chat. So let me just ask you one more question, and then we'll turn to the chat. As we've been talking, I think runners tend to know their bodies very well. So with that as the understanding, what signs or symptoms, whether they're experiencing it during exercise or otherwise, should runners discuss with their doctor? Like what should be, right, a cause for a call?
So there's a, sort of the typical symptoms that anyone, regardless of athlete status, can get that should call 911. So that's crushing chest pain, pressure, tightness, radiation to your left arm. When you're seated, it's worrisome for heart attack, call 911. In terms of, with exercise, there's some very nuanced things that can sort of be signals of things happening. So one is a change in running pace. So if you are, running a 7-minute mile and you're 52, and 6 months down the road, you can't keep up a 7:30 or 7:40 minute mile, that's a pretty dramatic change over 6 months
Mm-hmm.
that you shouldn't ignore. Unless you had a bad night of sleep and it was one day and then the next day you're back to your 7-minute pace, right? But if sort of you get a 2 or 3 days for no reason, your pace is slower, that's something that can be a sign of coronary artery disease or some cardiovascular problem. If you've been running for years, again, you know what normal feels like. So just listen to your body. If you've never had reflux when you're running, if all of a sudden 20 years after running, you're like, oh, I'm getting burning every time I run, that's probably not reflux. And that's probably coronary artery disease. If you feel like you can't keep up with your running group, so if you run with a bunch of folks and you've been had the same group for a couple of years and they're all aging the same, every year they're getting a year older. If you're the only one falling off and there's no explanation, don't just assume it's because you're getting older. They're also getting older, so there might be an explanation for that. So those are the biggest things is that sort of a new onset symptoms, burning, obviously any chest pain, jaw pain, arm pain. What we do see is that people who end up having heart attacks or events typically have had some type of signal or symptoms in the week leading up to it. And they've just sort of ignored it or said, I'm fine, I'm still running, things are okay. And so I think that's the big hallmark is that if you feel those things, make note of it and get seen.
I do wonder if, runners have a tendency to sort of run through it, right? And that is, if it's maybe a tweaked hamstring, that's one thing. But if it's something in your chest, that's probably something that you should err on the side of caution.
Yeah, absolutely. It just happens all the time, and my clinic is filled with folks who've had symptoms, sort of didn't know what to make of them, and then kept running, and then had an event. So yeah, it's something that seems obvious, but in the moment, it's easy to say, oh, I'll check in tomorrow, next week, or and um, again, if there's a clear explanation for it, I wouldn't get overly excited. But if there's no explanation, that's sort of when I would say, okay, something's up.
Some more tests. Okay, so let me start posting questions or positing questions to you from the chat. First, I had an aneurysm that was replaced, stroke fixed. Surgeon said I could do weights for bone density and strength. What limits might you suggest to not injure anything?
So it all depends on the underlying cause of the aneurysm. So if there's a genetic component to that, it's going to change how we recommend exercise. If you had genetic testing and there's no findings and the rest of the aorta looks fine, we might say that actually you potentially could have no restriction. So it's a bit of a nuanced decision based on all of your data. But if you've had a successful open heart surgery, your aorta is now fine and there's no genetic component, for the most part, when we have professional hockey players and football players come back to sport after aorta surgery.
So we have I think an update on that, which is a bicuspid valve causes I see there.
Yeah, so typically we do let most people return to sport. Again, the strength component is just how much. I mean, in general, we don't love doing Olympic max rep stuff, 1-2 reps. But it's doing 8 to 12 reps, 6 to 10 reps might be fine.
Interesting.
But that's going to be, again, specific to your information.
Yep. Okay, how bad is a calcium score of 131 for a runner?
Yeah, so that's a loaded question. It depends on sex and age, right? So an 80-year-old male, it might be okay.
Yeah.
So they also purely there's the absolute number of the calcium score, and then there's sort of usually a percentile that gives you a percentile relative to a person of your sex and age. And so if you're a 42-year-old woman, that might be extremely high. I saw the name as a female name. So if you are, so it depends a bit on all of that, but typically anything over 100 is considered high.
So obviously they've gotten it measured, and I presume that they're talking with a doctor about that. Yep. What is the relationship between heart health and cortisol levels? Let's assume patient has a clean cardiovascular history. So first, can you explain what cortisol is?
Cortisol is a stress hormone. And so, yeah, I mean, I think in the more recent I don't know, 5, 10 years, we've understood that stress and those sort of negative hormones play a role in heart health. And we think about the CEOs of companies who have heart attacks and otherwise are quite healthy. And so, yes, that plays a huge role in how we sort of think about things. There's some specific inflammation markers of the heart we sometimes check called high sensitivity CRP, and other things to help sort of package everything. But ultimately, I mean, it depends on the underlying cause. And so if you have high cortisol levels from a specific thing, we would work to try to manage that primary condition, and try to fix that problem instead of addressing sort of if you don't have any heart history right now, not impacting the heart, but to target the underlying cause of why you have a high cholesterol, high cortisol or stress levels.
Hmm. I know that exercise can help with reducing stress. Is there a relationship between exercise and cortisol levels?
Yeah, I mean, so the story is similar to what we're talking about. So cortisol levels, inflammation all decrease when you go from doing nothing to sort of a good couple hours a week of exercise.
Hmm.
As you do more and more and more, there might be a slight uptick in inflammation actually. But in that sweet spot of moderate intensity, a few hours a week, you get reductions in all of those numbers.
Hmm. Another reason to keep running.
Yeah.
Can you please discuss the use of statins and their potential side effects for runners?
Yeah. So you started this by saying don't try to get your medical advice online, and I agree with that because this question is all over the internet. So if you look at the big studies, they've done thousands of patients who've taken a water pill and a statin, and those both groups have ultimately the same side effects. So the idea is that just taking that tablet makes you feel something. And so for most people, they do just fine on
Hmm.
taking a statin. If you need it medically, it's not sort of a contraindication. I've got Ironman triathletes, marathoners, elite athletes
Mm.
who take these medications do just fine. There's a small cohort of people who have real side effects from them, and then we can stop, change the medication to a different type of statin. Sometimes that's very helpful. Or now there's other classes of cholesterol medications that we can go to if it's depending on how severe the disease is. I will also say that we can sort of tailor the program. So
Mm.
we know that if you're doing high volumes of running, we're building up for a marathon and you're gonna do 22-mile run or do the marathon itself. For my practice, again, shared decision making, I will sometimes have the person hold it for a day or two before a long run because that minimizes the risk of having side effects after a long run. So you take it 5 days a week, in those couple weeks leading up to long runs. So I wouldn't do that without talking to any cardiologist, but there's some strategies you can do to make it more tolerable while we're still treating your risk factors.
That's really impressive. So work with a sports cardiologist who can then understand what your goals, what your objectives are, and then you can work together and make a decision, an informed decision based upon what the runner is comfortable or trying to accomplish, what, sort of the risk tolerance is, all of those sorts of things. But at the end of the day, there's all of this flexibility. I did not realize that. I know there are classes of statins, but you just suggested something I never would have thought of, which is reason number 1,000,001 why you're a sports cardiologist and I'm sitting here asking you dumb questions. So do blood oxygen levels have anything to do with the heart, or is that solely a lung performance metric? And is that meaningful for runners?
Yeah, I mean, oxygen saturation is definitely meaningful because if you have low oxygen levels, you're not going to be able to perform as well as you wanted to.
Hmm.
There's a lot of causes. You can have primary lung issues. You can have holes within the heart. So blood can, instead of sort of going through a nice parallel or nice full circuit through the heart, there can be communication. And so you can be bypassing the lungs. And so you
Mm.
won't get the oxygen and
Mm.
that'll decrease your overall body oxygen levels.
Mm.
So there's sort of causes from both ends. But definitely really important. If your oxygen level is low, definitely want to figure out why and have it treated if you can, if it's reversible.
And I suspect you would feel that on a run if if you didn't have an oxygen level that was sufficient. You would be, to your point earlier, you'd be running slower, what have you.
Yeah, I mean, part of that depends. If you've had it your whole life, you might not know what abnormal feels like, and if it's not traumatic,
Oh, interesting.
right? So you might just be accustomed to it if it's something you've been born with, if it's a congenital problem.
Yes.
Um, I'm assuming it's not going to be dramatic if you've already hit 40s or 50s, but even a subtle change when you're running might impact performance.
Interesting. And Dr. Shah, are you okay going a few minutes over? We have
Yeah,
a few
yeah,
more
sure.
questions. Thank you. So, how do menstrual cycles impact things like resting heart rate variability, and other metrics we've discussed tonight?
Yeah, that's a really good question. I mean, as we started off, we need more data on female athletes. There's been a lot of push for the younger competitive athletes, so college, Olympic, professional, to sort of gather some more data and understand how this all works. There's some specific groups, some based in the UK, that are working with female athletes to target their performance and try to create training schedules based on their menstrual cycles, because we know there are changes. And so a lot of people perform worse and feel worse during their cycles. And so I think there's some coaches out there, and like I said, some groups that are trying to tailor training based around that.
Did I see on your website, I didn't click on the link, but it looked like there was a link where they were seeking elite athletes, and those are defined as, I think, from Olympic class to collegiate to sort of nationally competitive. I think there would be a few people actually on this call who might well fit that bill. Could you explain that, please?
Yeah, so a lot of the data that we have in sports cardiology has been retrospective, meaning we've had, say for example, you have my clinic, and then 5 years from now, I will take 300 of my patients, look back, and then sort of present that data going forward. But we didn't prospectively collect it. We didn't collect the data and follow people longitudinally over time, and so we didn't control for things. We were just sort of taking whatever we could and then passing it forward. And the studies that were prospective, meaning started at time zero and followed people for a few years, were either small or very short. And so as part of what we're doing a lot in sports cardiology is going away from what's called paternalistic medicine, where I tell you what's right and wrong for you without really taking it all into consideration, what's important to your life, and going into the shared decision making. And so as part of that, it's really important to understand how the outcomes or what's happening to these athletes as we do the shared decision making. And we're working with athletes for them to compete professionally with different forms of heart disease. So the study is called ORCA. I think they've just introduced it to pediatric population, but I think the upper end is 35 years old. So it's athletes with heart disease who've either chosen to continue to play sport or chosen to, take themselves out of sport. And we're following them over time to see what's happening to them. It's a fantastic study. A lot of my colleagues are running it around the country. If you do have heart disease and you're a competitive athlete, please, you can go on yourself and register yourself, or you can ask your physician to do it for you. ORCA, ORCCA. It's like the outcome registry in competitive athletes.
I've just put that in the chat. Do you know, I guess, Google search, or is it available through your website?
It's available on my website. There's a link that's, let's see. I think there's a link at the end that says like helpful links. And then actually, for those of you who are interested in supplements, there's some of the data from the US Olympics that we give to the athletes on supplements and diet in there too.
Interesting. And so if you could, what is your website address?
So it's www.sportsandperformancecardiology.com.
Sports and, you know what, I'm just going to go, let me search that. I'll put that in the link here. Bear with me here. I'll do this live. I had your page open earlier, and let's see. So where are we here? There we go. I think that's actually your about, but people can navigate through that. Could you explain how beta blockers and diuretics affect running performance, pace, and heart rate?
Yes, start with the diuretics. And this is where we start in the beginning. It's like depending on the cause of why you need diuretics. For most of us, for high blood pressure, we won't use diuretics in endurance athletes because they impact volume status, cramping, electrolytes, all of those things. And so we have two other classes of drugs that we typically go to, or three other classes of drugs we typically start with. Now, for some people, based on your underlying cause, you might need a diuretic, and then we just have to work with you to figure out how you stay hydrated and stay safe. But typically for high blood pressure, we avoid it at all costs. Beta blockers is a tricky answer. For most people, beta blockers are actually okay. And so if you have a low resting heart rate, beta blockers don't typically reduce your heart rate further. And so if your resting heart rate is in the 40s, if I have a patient who needs it, I will start them in on a beta blocker because it doesn't reduce typically any further. In terms of the maximum heart rate, it can limit your maximum heart rate, and it can impair performance. I don't avoid it. What I usually do is if someone needs it, I will start them on a beta blocker and sort of go through the testing and see how they do. A lot of people do fine. So I don't like to sort of put it in their head and they're going to feel poorly on it. It's like, if you need it, let's try it. And if there's something wrong, then we can sort of try to figure out how we either use alternative medications or alternative dosing patterns to make it work.
Is this one of those areas where when we started off this call, you were describing how sports cardiologists are looking at I guess, a different segment of the population than regular cardiologists? When you look in a cardiologist waiting room, as I've spent time, I look around, I don't really see a lot of people who look like me. Is this one of those areas where a sports cardiologist can, probably get a different take than what you might get from a normal cardiologist? Not denigrating normal
Just a different
cardiologists.
population. Yeah, it's just different populations, different understanding, different expertise of how we think about things. And so, yeah, all the medications we prescribe, we're going to sort of say, how's that going to impair you or not? For a strength athlete, beta blocker might be totally fine. For someone who's trying to run at maximum heart rate, it may limit you. Again, I usually, if you need it, I usually try it.
Mhm.
Again, it depends on the person. Some people do just fine on these, including endurance runners and endurance athletes. So it's specifically tailored to you of how you tolerate it or don't tolerate it.
And of course, I guess there are different sort of beta blockers out there too, right? Which may have
There's
different
short acting, there's
performance or
24-hour ones, there's different types. And again, it really depends on why you absolutely need it. If it's for AFib and your heart's structurally normal, we can sometimes use something called a calcium channel blocker that may be just as effective. If you've got coronary artery disease and something, then you may need the beta blocker. So there's a lot of nuance of how we pick the meds. It all depends on your personal story and why you need it.
gotcha. Next question, are you accepting new patients?
Yeah, we are. Yeah, we absolutely are.
And you're not far off the CCT. So if somebody were so inclined, although I don't know how you would need a sports cardiologist, except maybe you were doing a VO2 max, but you could always just sort of run to your office. It's very close. But yeah, so you're in Bethesda, you're local, which is amazing because we get athletes coming to you from all parts of the country and world. And so for us to have you locally is truly a special thing. So um, how would people, if they wanted to get in touch with you, could they go through your website? I guess your contact information is there.
If you go on the website, there's a contact us section. You can put your info. We can call you, or you can call. There's the office numbers on there. You can call during business hours, and we'd be happy to sort of connect and schedule.
Perfect. Okay, two more questions, and then we'll release you from our hold. What is the prevalence of AFib, so atrial fibrillation for endurance runners? And can you explain again what atrial fibrillation is, please?
Yeah, so the normal electrical circuit is sort of a very coordinated effort. So you start with something called the sinus node, which is essentially the pacemaker of the heart, and that sends a signal down for top chambers to squeeze, and then it sends a signal down to something called the AV node, which is the next sort of gatekeeper, and then that sends a signal down to the two bottom chambers, the ventricles, to squeeze. So it's a very coordinated effort that makes things efficient. When you have atrial fibrillation, instead of having that pacemaker firing, you have typically something where in pulmonary veins, which is what enters the left atrium. So in the chambers, you have like thousands of these little things firing, and it makes it very uncoordinated. And it's sort of, instead of squeezing nicely, that part of it is just quivering. And that leads to a couple things. Typically doesn't have a risk of sudden death with it, but it can lead to impaired performance for a runner or an athlete because it's not going to be coordinated. Depending on your risk factors, it can lead to an increased risk of stroke. And then for some people, your heart can get weak with it. And so it's obviously it's something you need to pair with someone and figure out what from your personal history and how you want to manage it. Most people, we try to get you back into a normal rhythm as a first or second time because especially athletes, typically do better in normal rhythm. In terms of the prevalence, so it's higher than their sedentary counterparts if you're doing long-term high volumes of running for years. The data is sort of all over the board, but anywhere from 2.5 times to 5 times more likely compared to the sedentary population. But an absolute number is hard to give. Like
Yeah,
your 2% risk for endurance runs, we can't do that.
right. And should it be a cause to not run?
That's a personal preference. I mean, I typically say no, meaning if you love, again, this is the idea of what do you need to do for heart health versus why are you running 10 hours a week? And so if you're running 10 hours a week because it is your drug, it is your mental health, it is your joy, then I typically say if everything else checks out and you don't have AFib, it's something that we will work together and manage if it comes up. But for people who say, no, I really don't want it and I don't need to run 10 hours a week, then I'll say for heart health, you can run 2 or 3 or 4 hours a week and you'll be great.
Interesting. Okay. And then our last question, are high LPA rates common among runners? And so I guess if you could explain the various types of cholesterol here so we know what LPA means.
Yeah, so the LP little a has gotten a lot of attention in the last few years, and it's sort of an independent risk marker of cardiovascular disease, and so increased risk of coronary disease, of strokes, of what's called like higher risk of heart attacks. And it's something that typically doesn't change with your lifestyle. So it doesn't change with exercise, diet, weight. For women, we know that it actually does go up after menopause. But other than that, there's not been too much variation. The data is still sort of coming out. I just read something the other day. Now they're sort of maybe thinking about checking it twice in a lifetime. But at present, we're typically checking it once in a lifetime for everyone. It's recommended. If high, we don't currently have a drug to treat that both lowers the number and reduces events, which is our ultimate goal. Is like you don't want to just treat a number, you want to make sure it decreases heart attacks or strokes or other things. There's a couple of drugs that right now will treat the number, but we don't have any hard data that it reduces events. And so as a surrogate, we're trying to maximize treatment of all the other risk factors. So if you're high blood pressure, diabetic, or have high cholesterol, the LDL, we really want to try to target those as a surrogate, because now you have that sort of additional LP little a risk factor. There are a couple of drugs, 3 of them in sort of late trials right now, and I suspect they'll be proving that they can lower the LP little a plus reduce events. And depending on who you talk to, but anywhere from 2 to 4 years, 2 to 5 years, they'll probably be available on the market to actually treat that in itself.
Is this something that we're asking common among runners, but this feels like one of those instances where maybe for endurance athletes or runners, the distribution or the prevalence is the same as for the general population because it's not correlated with exercise. Is that right?
Yeah. I don't know of any data that says that runners are specifically increased risk, but I am checking it in all of my patients once. And then if you happen to be a runner, that's fine. Like I said earlier, if you're already running 6 days a week, 50 miles a week, and your cholesterol's high and this is high, I'm going to say we should treat it.
Interesting. Yeah, and that's something that's very new because I don't think I've ever had it checked, just the regular sort of LDL, HDL.
Yeah, I mean, it's sort of gotten a lot more data behind it, and now the recommendations have sort of come out. And so for most of us, we're checking it as sort of a routine thing now when we check the cholesterol.
Well, with that, we've come to the end of our questions, although I could ask you a million more, and that's probably why I get anyway. So listen, Dr. Shah, thank you so much for your time, for your answers, for your patience through all the questions. I can't thank you enough. So if anybody is looking for a sports cardiologist, either through referral from their primary care physician, or I guess even going directly to you, then you're accepting patients, which would be lovely because you are local. So with that, any last closing thoughts or comments?
No, I just appreciate you setting this up and allowing me to do this. I think, that swimmer article just came out, and I got a couple calls from around the country. I've had a couple people fly, and they're all like, we didn't know sports cardiology existed. And so I'm hoping we do a better job on our end of sort of making this known that for active people, there's a whole subspecialty of cardiologists you can work with, that hopefully will help sort of fine tune things for you.
Yeah, and I'd just like to close out by thanking the club for agreeing to sponsor and host this, Johnny Pellish for handling the technical, Peter Feltman, and Jill Brasky for making it happen in the club. Thank you all so much. I know that it took a while for us to get here, but it was worth the wait. So again, thank you for your time, Dr. Shah. Thank you, everybody, for joining. And with that, I'll close the meeting out. Everybody have a good night.
Wonderful. Thank you.
All right, bye-bye.